Hello, my name is Badeepa Chaudhary, and I am the Health Equity Coordinator at CASA. I want to welcome and thank you for joining us today to celebrate the 20th anniversary of South Asian Heritage Month. I would like to begin today's panel discussion with a land acknowledgement. We are grateful for the opportunity to gather virtually on this land and thank the generations of Indigenous people who have taken care of this land long before other nation groups came. We acknowledge that the work of CASA takes place on traditional Indigenous territories of the Huron-Wendat, the Haudenosaunee, and the territories of the Mississauga of the Credit. This territory is part of the Dish with One Spoon Treaty, an agreement between the Anishinaabe, the Haudenosaunee, and allied nations to share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today, Toronto, the traditional Mohawk name of this area called Toronto, meaning trees in the water, and its surrounding areas are still home to the Indigenous people. And we are grateful to have the opportunity to meet, work, and play on this territory as settlers. We wish to express gratitude to Mother Earth for the resources we are using and honor all the First Nations, Métis, and Inuit people who have been living on the land since time immemorial. This recognition of the contributions and historic importance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities. As today's session focuses on mental health, it is particularly important for us to recognize the severity of mental health inequities in Indigenous communities. We stand in solidarity with Indigenous communities in calls to all levels of government to develop Indigenous-led mental health policies and practices that are informed by Indigenous healing practices. We must hold our government and health institutions accountable and advocate in increasing access to health care for Indigenous people. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the health and well-being of Indigenous communities. I encourage everyone at this session to actively seek information and take action, especially as we recognize the National Day for Truth and Reconciliation on September 30th. At this time, I would like to invite Sangha Chakske, the chair of the board for the Council of Agencies Serving South Asians, to deliver the welcoming remarks.
Thank you, Badeepa. Amazing panelists, dear supporters and friends of CASA, I welcome you to our 2022 South Asian Heritage Month event. Today, we have an important issue at hand, and that is mental health among South Asians. We recognize that South Asians are disproportionately affected by mental health, mental illness. We're also aware that the stigma and discrimination around mental health that exists in our community can be more harmful than the illness itself at times. Our South Asian community suffers from this illness in many ways, and to name a few, anxiety, stress disorder, acculturative stress, depression, and various forms of traumas, including that caused from war. Some of the existing mental health issues that were known to us were further made complex by the disproportionate effects of COVID-19 and its accompanying racism and discrimination on vulnerable communities, and that includes our South Asian community. And to top that, the year 2021 also witnessed our Afghan brothers and sisters who fled here as refugees of war and who came here with many mental health needs and challenges that are caused by prolonged war and the sudden invasion of the country. Personally, I, as an Afghan refugee of war and settler into this land, have gone through vicarious, or what we also refer to as secondary trauma, as I watched thousands of my fellow refugees escape from war like I did once when I was a child. So I could easily say that I relived my past by watching them flee the situation in the country. And I'm certain that my narrative can be the narrative of thousands of others who had to revisit their past traumas as they watched the incoming flow of refugees. So it is without a doubt that we will need to bring transformational change to mental health service delivery. We also need to acknowledge that understanding mental health among South Asians and providing the most appropriate intervention requires an approach that has to be intersectional in nature. We are in need of culturally appropriate health services. Mental health services to be specific. And this could mean more training must be provided to non-South Asian professionals in this field serving mental health patients that are South Asians. We would also need to have more South Asian leaders and experts in the fields of mental health in terms of policy making. So this could, ensure more representation or better representation for South Asians. Luckily, CASA has been or has often engaged in policy roundtables and has hosted panels regarding mental health issues impacting our South Asian community. To be precise, in our 8th annual Health Equity Summit, we successfully hosted a series of panels, including one on mental health and its impacts on our community. Some of the recommendations by experts that were shared with us included, but we're not, of course, limited to developing anti-stigma strategy. Focusing on intersectionality of health issues, example, spiritual and social aspects, connecting with religious leaders and encouraging doctors to speak about mental health more, therefore normalizing it. Understanding the needs and the importance of mental health in our community is what has led to this year's theme for our South Asian Heritage Month poster. And we're grateful to all the panelists who have made incredible contributions to the field of mental health by creating safe space for conversations, introducing innovative approaches, and advocating for better mental health support in the South Asian community. I personally feel privileged to be sharing this virtual space with such amazing group of trailblazers. And folks, with us today, we have Dr. Farah Islam, Dr. Farooq Naeem, Dr. Parvati Kanthasamy, Maneet Chahal, Jasmeet Chagar, Dr. Rapudaman Singh Minhas, and Rita Coley. With this, and without further ado, I'd like to pass the virtual torch to our amazing Executive Director, Samya, who will take you to the most and more interesting part of the conversation today. Thank you, folks, for joining once again.
Awesome, great. Thank you so much, Sangha, for those really important words and a recap of some of the work that CASA has been doing on raising awareness on mental health in the South Asian community. I actually want to turn it back to Madiba and Yamna. We do have a few delegates in the audience who wanted to say a few words. So I'm going to promote them as panelists, and if they are here and they want to say a few words, you have a minute to say your greetings. So back to you, Madiba.
So I'd like to give a brief shout out to our special guests who will be joining us today. First, I would like to introduce Sonia Sidou, a member of Parliament for Brampton South, to share her greetings. Sonia, would you please take the virtual floor?
It's great to see so many familiar faces. This is very, very important panel. As you know, after 2 years, definitely lots of population got impacted from mental health issue. And thank you to the Council of Agencies Serving South Asians for all of your work and for this opportunity to deliver quick greetings. And I see Dr. Rapudaman Minhas and Ms. Sangha for your touching opening remarks. I know a month ago I was at the launch of Colin Tillon's book, and we had I heard great discussion from Soch on the importance of breaking down the stigma surrounding mental health, especially in the South Asian community. We all know we don't want to talk about mental health, especially youth is struggling with that. South Asian women, I'm a vice chair of Status of Women Committee, and we are working on the report stage on intimate partner violence, which is like women hit hard on many issues, mental health, intimate partner violence. And the experts, we are hearing a lot of tragic stories, which is not acceptable. It's happening, and then especially from PL. Even though today we had a meeting with the chief Nish and many other police officers, and it is on police radar too. And then thank you all the work SOT you are doing, and many other organizations. Thank you so much. Much needed work need to be done. Mental health is a physical health, and the pandemic has worsened that the impact. And the main thing, people don't know the symptoms, especially some communities. And thank you for raising awareness. It's so important to see the awareness, and then even the virtual health. There's a pocket dial which I can type information in the chat, and it's a free resources. And if you can provide those resources, that will be also wonderful. So I'm looking forward to hearing your perspective. I see Bardish here, my colleague. Nice to see you, Bardish. And thank you for putting up a great panel.
MP Bardish, would you like to add anything?
Thank you so much, Sonia. It's great to see you. I will just say that I'm Bardish Chagar, the Member of Parliament for the riding of Waterloo, joining you from Waterloo, the traditional territory of the Anishinaabe, Haudenosaunee, and Neutral people. I think it's very important that we acknowledge the land, and the acknowledgement that was shared with all of us today was so fitting, because we need to know where we come from to know where we're going. And when I received this invitation, I was ecstatic, because I was going to see 7 mental health advocates, 7 leaders from our community, really recognizing the diversity of needs when it comes to mental health, because we're all on a journey. Mental health is very important. Everyone has their challenges and opportunities with it. And even as we referred to with the picture, it was nice to see the positive side, because if we take care of our mind, body, and soul, all of us will be healthier. And the way to do that is really by lifting each other up and being there. And I know we talk about normalizing, but humanizing it. So I really want to thank all of you for being vulnerable and creating this space for us to be able to listen and learn, and to be able to be brave together. I want to give a shout out to CASA as well. And congratulations to all on the 20th anniversary of Asian Heritage Month, and for you all actually bringing light to South Asians. And I want you to know that when it comes to Canadians of South Asian descent in Parliament, I have never been prouder of the men and women that we have elected across this country. We are lifting each other up. We are creating more spaces, because we know that we want to see more elected in every level of government. So thank you so much for all that you have done. Thank you for creating this space. And special shout out to the 7 leaders. And I'm not often on a group like this where there's 2 Chagars. So I'm going to say that there's one that's got my heart the biggest. So just means it's great to see you. It's great to see all of you. And I can't wait to hear you. Please, everyone, keep well and safe. Until the next time.
Thank you, Sonia and Bardish, for taking the time out of your busy schedule to celebrate with us. We really appreciate it. I'll just turn it back to Sonia to close off and wrap up the opening remarks.
Awesome. Thank you so much. I feel like whatever I wanted to say has been said already, so I'm just going to pass it back to you. I'm kidding. I have a few words, but it'll be short because I am looking forward to the panel discussion, and I want to give the panelists as much time as possible this afternoon. So as Madiba mentioned, my name is Samia Hassan. I'm the executive director of this wonderful organization called the Council of Agencies Serving South Asians. For those of you who are attending your first CASA event, just a little bit of background background about who we are and what we do. We are a social justice umbrella organization, and we serve organizations and groups that serve South Asian communities in Ontario. And more recently, actually, we are serving organizations that are located in other parts of the country. So a little bit of a sneak peek into what's coming for CASA, and we're looking into that national expansion piece. We work with our members to advocate for the well-being of South Asian communities. We do training, we do advocacy, we do public policy, we do consultations, and we do capacity building for the community and for organizations that serve the community. Currently, we have over 120 members that are expanding nationally. And if you're part of the audience and are not aware of how to access membership to CASA, please be sure to get in touch with one of the event administrators today, and we can help you out with that. So as Senga mentioned, our South Asian Heritage Month initiative this year is focused on mental health supports and advocates. But how we came to this journey, it actually started back in 2016 when we started creating these posters to highlight South Asian Canadians of excellence. And back in 2016, we focused on South Asians that did a lot of human rights activism in Canada. Then we, in 2017, we shed light on South Asians of excellence during the 150 years of colonized Canada. After that, it was civic engagement advocates, then gender equity champions, then environmental justice activists. Last year, we focused on COVID-19 heroes, and this year we're doing our panel and our poster on mental health advocates and supporters. So before the pandemic started, we know that there has been a lot of research and studies done, and even anecdotally, that South Asian communities, there has to be a lot of work that needs to be done on mental health. But since the pandemic has started, the needs, as we've already highlighted, and I'm sure it's going to be highlighted more, have exacerbated. And the mental health outcomes for South Asians have deteriorated. So again, I'm not going to go into details, but I will acknowledge the complexities of the work that's involved. And I appreciate, and we all appreciate, everything that it takes to do work in the field of mental health for South Asian communities, as mentioned already by Sanga and others, that you're dealing with a very different type of stigma. You're dealing with the impact of immigration. You're dealing with the impact of racism, of language barriers, of changes to your lifestyle. Sometimes people are coming from war zones. There's generational communication gaps and so many other factors that we're going to hear about today, which makes this work so challenging. So I want to give another shout out to the 7 panelists that we have today, and the leaders in the South Asian community that are doing this work and working with people that affects in a field that affects people of all ages, of all backgrounds, of all faith, of all genders. We know everybody's struggling with this. So I'm really looking forward to hearing about your work and how we can work together and how we can collaborate and how we can connect and have greater impact in this field. So without further delay, I'll pass it back to my colleagues, Madiba and Yomna, who are really the people behind putting all of this together to take us through the rest of the program. Thank you.
Thank you, Samia. And once again, thank you to our special guest and Sangha for sharing your sentiments. Moving right along. So if you have any questions during the presentation, please type them into the chat box and we will address the questions towards the end of the event. Please also don't forget to share your excitements and thoughts on social media. Remember to follow and tag our Twitter, Facebook, and Instagram handle at CASA Online, and use the hashtags South Asian Heritage Month, Mental Health Awareness Month, and Mental Health. Now, without further ado, let's introduce our panelists for today. As evident with our poster, we will be celebrating 7 South Asian mental health practitioners and advocates for South Asian Heritage Month. Today, we will be joined by Dr. Farah Islam, Dr. Farooq Naeem, Dr. Parvati Kansami, Minnie Chahal, Jasmeet Jagger, Dr. Rubiraman Singh Minhas, and Rita Coley. And I just want to say that these individuals have done so much for the community, but it is a shame that we had such little space to display their work and achievement. So please do look into these amazing individuals if you have the time. Now let's get started. Okay, so Dr. Farah Islam is a mental health advocate, educator, and researcher. She explores mental health and service access at the intersection of faith, migration, and racialization, and works on eliminating the barriers of mental health stigma. She serves as the director of the Psycho-Spiritual Department at the Yaqeen Institute for Islamic Research. Dr. Farooq Naeem is a professor of psychiatry at University of Toronto and a psychiatrist at CAMH. He published nearly 200 peer-reviewed articles, 6 books, and numerous therapy manuals and chapters. Dr. Naeem pioneered techniques for culturally adapted cognitive behavior therapy, now used in South Asia, North Africa, the Middle East, Kenya, and China. Dr. Parvati Kandasamy is also involved in counseling activities to alleviate women's grievousness and has researched women, seniors, and people with mental illness. She authored professional articles in mental health books and works with Vasanthan to uplift the mental health of Tamil citizens, providing hope for victimized women and vulnerable seniors. Manit Chahal has over a decade of mental health nursing experience. A thesis Manit completed for her Master of Science in Nursing examined the experience of the Punjabi community in Peel in accessing mental health services. She co-founded Soch Mental Health, which provides culturally and linguistically appropriate mental health promotion for South Asians. Jasmeet Chugger has over a decade of mental health experience. A thesis Jasmeet completed for her Master's of Science in Nursing explored the perceptions and the impact of alcohol use on Punjabi families. She has co-founded Soch Mental Health alongside Manit, which again provides culturally and linguistically appropriate mental health promotion for South Asians. Dr. Rupadaman Singh Minhas is a developmental pediatrician and an assistant professor. His research includes the development, behavior, disability, and rehabilitation of children in urban settings and newcomers, immigrant, and refugee families. He supports parenting in marginalized communities and develops child development interventions. Last but not least, I want to introduce Rita Coley, a registered psychotherapist and traumatologist who works with people of different race, gender, ethnicity, and sexual orientations from a strength-based approach. Rita has over 3 decades of experience in a non-profit and post-secondary sector and her lived experience as a survivor living in exile within exile. Again, thank you so much to our leaders for joining us today to share their perspectives on mental health issues impacting the South Asian communities. And with that, I'm going to pass the virtual mic to Yamna, who will be moderating the panel discussion today.
Thank you so much, Madiba. Good evening, everyone. First and foremost, happy South Asian Heritage Month and also Mental Health Awareness Month. My name is Yomna Omar. I'm the project manager here at CASA, and like Madiba said, I'll be moderating today's panel. So I'll just get started right away. As Samia said, we want to give the panelists as much time to speak as possible. We do have some questions today for our mental health advocates, and they each will be given about 2 minutes to reply to each question. Please feel free to jump in if you feel like you want to answer a specific question or if you want to add on to each other's answers as well. Otherwise, I'm going to have to pick on you and call out people's names to actually answer. But yeah, so we can start with the first one. We know there are many challenges surrounding mental health in general that people face, but we would like to know what are some of the challenges around mental health that South Asians uniquely face, and do you have any suggestions for how to address them? Does anyone want to go first?
So I don't mind starting. I think
Dr.
there
Farah was
are.
smiling, so I'm going to ask you to go first, if that's okay.
I'm like there are I think a lot of challenges that impact, ethnic minorities, specifically with South Asians, and I think this might replicate concerns in other ethnic groups. I think it's the understanding and awareness about what mental health is. So working in the field of mental health for almost a decade, when people are caught within the mental health system, they have no language, they have no understanding of what that experience is and what they're going through. And I think that ends up being the biggest barrier in terms of delaying intervention, getting help. And even when you are getting the help, to understand, what is it that's actually happening to you? What does this experience mean? What does it mean for your health? So I think that in itself is extremely challenging. And what you usually see in mainstream services is that, we're coming up with more services, we're coming up with more psychiatrists, therapists, services that are offered, but our community is not getting to there because no one's really gone in and done that work in terms of breaking that stigma, using culture and language to really educate and empower them so they know, first of all, what it is that they're going through, and get help, I guess, in a timely manner. So what can you do? What are suggestions to address this? I think it's really empowering the community at large about mental health and using culture as language, using ethnocultural media outlets, using storytelling. I think these are some of the strategies we've been using at SOCH, and it's been very impactful. In research, they talk about use unique cultural strategies, but what does that mean? Like, how does that translate in your day in, day out? There's a lot of barriers as well. Like, if you try to make an initiative, you try to go to faith-based institutions, there's a lot of blocks within the community about what are you doing? Like, how does this make sense? So again, these are the challenges. But I think when you really simplify it and you also empower community members to educate others, I think that's how we can address it. When you have your everyday person educating their neighbor, their friends, their colleagues about mental health, and really using that language and storytelling, I think that's the way to kind of go about it. But that's the biggest thing we see. People don't understand and don't see that mental health exists, and we just kind of use that as an excuse, like, oh, they're not open to it or whatnot, but no one's gone in to do that hard ground level work. I think agencies are trying, but I think what we lack is the community voice at a lot of agencies. That's the biggest gap I've seen working in the hospital and in the community. We don't have representation from our community.
Thank you so much. Thank you. Jasmine, would you like to go next?
I'm just gonna say it right now. Manit and I, since we work together, we have our answers are probably going to be very similar. So I'm glad she started off. But some of the things that she was mentioning, like the mental health literacy, kind of got me thinking. There's also a lack of representation in social media campaigns. It is starting to be a little bit better now. Like, for example, a few years ago, Bell Let's Talk had one of their first South Asians appear in the campaign. But I think that also talks to what Manit was speaking about. We need a lot more health promotion for the South Asian community in order to address that gap of that lack of the mental health literacy. So if there's more representation in these campaigns and we're seeing faces that look like us, then we're also starting to, destigmatize that mental health conversation that, oh, this person looks like me, so maybe what I'm going through is normalized and it's okay to have these issues that I'm going through. And even with that, I think like there's a lack of space for our community by the community. Even with us, like when we were trying to, this is pre-pandemic, when we were out in the community looking for space, we wanted to go where the community was. And for us, oftentimes that's at faith-based institutions. Because with a lot of South Asian faiths, when you go to the mosque, the mandir, the gurdwara, the churches, whatever it is, it's not just a place of worship, it's a place where community members come together to also socialize. So if the community is there, that's where the mental health promotion should be happening. but there's a lot of difficulty getting into these organizations, into these faith-based institutions. So it's also going back to promoting mental health within our community so that they understand why, we are doing the work that we're doing, and that our community needs a safe space to have these conversations. That's also very important. And that's probably one of the suggestions in terms of, that community aspect. Our community first needs to understand. After that, that's when, other communities, the government, individuals that are not part of the South Asian community are going to support us. But first, it needs to be our own community.
Thank you so much, Jasmeet. Dr. Faroo, would you like to go next?
Thank you. So first of all, thank you so much for inviting me to this panel. Really privileged to be here. I first of all agree with what Maneet and Jasmeet said. And in addition to that, I think on a broad level, on a systemic level, I think we need to think about 2-3 things. One, you can't make any change without numbers, full stop. I was surprised when I actually moved here to Canada 7-8 years ago, and you can remove the first 3 years because I was in Queens, so that was totally dysfunctional 3 years. And now that I'm in Toronto, I know a little bit more and meet with South Asians, etc., etc. You see, most of the research on South Asians comes from UK, and that's why you'll see the most impactful, meaningful involvement and engagement of South Asians in UK compared with, don't hate me for saying this thing, okay? I'm just trying to just speak my mind. We need numbers. We need research to show how many people have what kind of problems. We do not have we have only one single survey that directly looked at the number of post-PTSD in Sri Lankan people. The second paper, and that's how I got to know Farah, was actually by Farah on South Asians. I think it's 1 or 2 papers, but that's also, Farah, am I right? That's also indirect from the Canadian Health Survey. So it's not like a community survey. So we still don't know how many South Asians in America or in Canada have mental health problems. That is a very important thing. And you can't, if you don't have numbers, you can't talk to your counselors, you can't talk to the government, you can't do anything. Full stop. Second is the engagement of politicians. And again, and I apologize, I think I had 2 honorable MPs. So forgive me for this. I don't know how engaged your politicians here are. Without engaging the politicians, again, you can't do that. And politicians can't do anything if they don't have the numbers. Okay, so there's the kind of dilemma we have. The third, and I'm trying not to repeat what Jasmeet and Maneet have said already. Number 3, and I think that's a huge problem I see, and that is the myths. You have some interesting myths about South Asians in Canada and USA, right? Number 1, for example, you have very, it's the kind of biggest joke that I heard when I moved here, and that was health immigration effect. Come on, for God's sake, immigration is a stressful thing. I moved here as a full professor. I had my job lined up. They had, the university had even organized my house, car, everything. But the first 2 years were stressful. Then we moved to Toronto. And again, it was, so this is a huge kind of issue, really. Second, I think also, and again, I see this in North America, I didn't see this in UK, and that is South Asians are the ideal community. They are the most successful. So, I think you need to bust this myth as well. South Asians are all kind. I have seen in US, I've seen here, and and again, you can correct me, but I can see that there are poor South Asian, there are rich South Asian, there are South Asians who are between these 2 extremes. And again, in terms of education, in terms of healthcare, every other facility. So I think we'll have to work on these myths as well, that no South Asians are like other communities, like other migrants, and they have similar problems. So I think these are the 3 things that I can think of, that I just speaking money didn't say, so I rest my case here.
Thank you so much, Dr. Faroo, and thank you for this insight onto the systemic issues, and we'll definitely be talking about that more in a bit. Dr. Parvati, would you like to take the floor next?
I'm sorry, my throat, I have sore throat. My voice is not so good today. I'm a mental health worker at Frederick as well as at Vasandam. Vasandam is a wellness center built up on right after the mental health research that was done in 90s by the Mount Sinai Hospital, University of Toronto, and Wellesley Central that time. Dr. Sadawoy and Dr. Rosemary Meyer, who were the ones who who were leading the research. But that research report, plus there are other research reports, Dr. Baiza et al., they did the research in late 90s and 2000s. It is a CAMH, Center for Addiction and Mental Health. They did the research on Tamil's mental health with 1,600 people. And that research report is also there. And recently, I was involved with many research reports with Ryerson University and York University affiliation. We have done research on Tamil seniors, Tamil men, and right now we are doing a research on suicide study. But what we see is all this research people have been doing, the research funding was given, all the research reports are there with the Ministry of Health or, with all these organizations. But even CASA has done some research, but none of the research reports are taken into consideration in their, in the system to advocate or do services. That's what we are seeing, it's lacking. Because the South Asian community, as this the UK-based doctor, mentioned, they are different communities. They are they came from different different walks of life, like the Sri Lankan Tamils. That's where my research is based on, and they came from a country where they experienced collective trauma for so many years, and what we see in Canada, they just give pockets, pockets of funding with certain things, but they do not really take into consideration what they need. Say, for instance, even right now, we have seen quite a number of Tamil youth are committing suicide right now. Every week there's number of suicide, because I really collect data. Even 2 weeks ago, there were 3 young men. Earlier in the 90s when I started, young women were committing suicide. But during the COVID, early COVID onset time, there were quite a number of Tamil youths were into drugs, and about within 2 or 3 months, 35 plus young men, they died of drug overdose. So this is going on. Why this is happening, and what is happening? How many psychiatrists are here who can speak Tamil? How many psychiatric services or outlets, like in Peel region, because of the politicians, there is a Punjabi health center. At least they have the services. But in other regions, there's nothing. There's no Tamil services. There's no, there's Hong Fook Center, which was established. There's even the nursing homes based on, Chinese nursing homes are there, but there's no South Asian nursing homes. So, we are doing a number of research on Tamil seniors. They are experiencing tremendous mental health problem. So addiction is the major issue with this community. This is the #1 they are standing high with the addiction. So they have concurrent disorders. And who are the psychiatrists? How many psychiatrists are here? You know, there is only one Tamil psychiatrist who is doing inpatient. Right now, they appointed somebody for 3 days, it seems, and we didn't meet her yet. But there's no psychiatrist who can serve this community. And then the stigma. You know, stigma is a very, very, you know, affecting these communities really, really bad. So there are childhood trauma. You know, all the South Asian communities, you know, they have been experiencing childhood trauma and domestic violence that has really taken a toll on the women, because we have recently done, with the collaboration of Tamil Doctors Association, Vasantham has done some group work with the middle-aged women. You know, then we have seen quite a number of them are really traumatized, and their children, you know, you can understand how much the children are going through. And with the COVID, how many children have gone to online school and what they are suffering, and that we have seen. So I just wanted to, you know, let the system know the systemic barriers are the major barriers that, you know, we are experiencing in Canada. So I can continue on, but I will, you know, I can talk later. I let others to talk. Yeah, thank you.
Thank you so much, Dr. Parvati. Thank you. Dr. Ripudaman, can you please take the floor?
Sure, thank you. Can you hear me okay? There we go. So hi, everyone. My name is Ripu Minhas. I'm a developmental pediatrician, as was mentioned earlier. So, you know, as a pediatrician, I'm thinking also about the perspectives of children. And a lot of my work is in supporting young families and parents in their parenting journeys. So part of that includes, you know, how they support their children's health and development, how they navigate education and healthcare for them as well. And we know that those early years at home impact children's lives, but you know, we talk about these are the first 1,000 days from conception and how that impacts children's brain architecture. And really that's an irreversible time. That's really a prime time to support them. And so when we think about that and the experiences that families have, how to help us to support parents during those times in their parental mental health as well, I think it's really important. So I think one recommendation I think would be to focus a little bit more on intergenerational or multi-generational interventions and early childhood interventions, which is dear to my heart, because we know that if we can support families in the first few years of children's lives, there's a lot of data that shows that we can improve, you know, early childhood developmental outcomes, but that ties to educational outcomes and economic outcomes, which helps to lift entire communities out of poverty and out of the intergenerational trauma that we know that South Asian communities do experience with our histories of colonization, genocide, the traumas of resettlement and migration, and the things that are tied to that as well. The other thing I was thinking about is, you know, the other panelists spoke really nicely to the idea of representation. So I think having representation in campaigns, in the mental health workforce as well is really important. Through our work, so I run an Instagram health promotion program called Punjabi Kids Health, and we just rolled out a Tamil Kids Health channel as well. And a lot of our online community members have written to us to tell us they trust us because we look like them, we talk like them, we have similar names, and we're doing content in both English and Punjabi and in Tamil as well. And so we get comments from folks just saying we trust you because we know you share some lived experience with us, and that's easier than going to you know, someone who doesn't share that lived experience. It's not just language, but there's other barriers there as well. So I think representation, and as we think about the human resources and, you know, how our workforce is staffed is really important, as you know, the other panelists were talking about earlier as well. So I think those are the first things that come to my mind. And one other thing I've really been learning about is co-creation of content as well, or co-creation of intervention. So I think we really need to engage with the end users of these communities as well. And that is not necessarily us as the panelists, because we also carry, I think, relative position, power, and privilege within our communities if we're in a place where we're able to stand up. But I think for voices that are underrepresented within our communities as well, we need to engage with those, those communities that are marginalized within the margins, to talk about what their barriers are as well, and to look at how we can bring those experiences to light and how we can work on mitigating some of those barriers as well.
Perfect. Thank you so much. And I completely agree. I think what you mentioned about co-creation is very important. I think you always need to meet people halfway and kind of give them the autonomy and the kind of agency as well to determine how they want to be treated and have a say in how they access the services, what services are provided. Thank you so much. Dr. Farah, can you go, please?
Thank you so much. And a big shout out and thank you to CASA as well. I actually did an internship at CASA during grad school, so this is a very special treat. Thank you again, it's a big honor. I think when we're talking about challenges to mental health that South Asians face, I think we can see it across, three main buckets or main categories that we've all been talking about here, whether that's some unique stressors that we face as South Asian populations, for example, those associated with migration resettlement, like Dr. Naeem was talking about, intergenerational conflict, identity development, the racism that we face when we come to settle here. On another spectrum or on another factor is of stigma as well. All communities have faced mental health stigma, but we kind of have a unique flavor to it in our South Asian populations, whether that's a cultural flavor or a sort of misconceptions that come out of our faiths or our faith practices. So kind of having to deal with those stigma-related types of ideas and trying to develop anti-stigma initiatives that do honor those different types of ideas or knowledge bases that we do come from, whether that's within our faith spaces or in our community centers, is really important. And the other factor where we face challenges is, of course, the unique barriers that we face as South Asian populations when it comes to trying to seek mental health services. So the lack of cultural safety within the mental health system when it comes to having to access mental health services. So all of that together makes it quite difficult for us as South Asian populations in trying to ensure our mental health and well-being.
Thank you so much. Thank you so much, Dr. Farah. Rita, last but not least.
Hi, everybody. It's quite late in India, early morning rather. I'm sitting here and engaging in this amazing panel that has been put together. I have some historical context with CASA. Won't talk about it at this point. So I want to sort of look at the content that has been put together within the uniqueness of the South Asian community and related to mental health. First and foremost, we have to deconstruct the notion of what is mental health versus mental illness, and to demystify those kind of things. So I'm just going to speak to that because they're different things. As somebody who's a very successful activist, practitioner, etc., it doesn't mean I don't have mental health issues. I could also have mental illness. And that can be used as a basis of connecting with people and being able to speak publicly about it without it going to a place of shame of any kind. Having said that, I'm going to pick up on some of the themes that were put together forward. That's the benefit of going last. Thank you for putting me last. I like that. So one of the things I'm going to say is that both from a policy perspective and on the ground, we can't look at the barriers related to mental health within the South Asian community, which is very diverse. There are barriers and challenges are soft words for discriminatory practices that our populations who are very vulnerable when they're going through some kind of mental health crisis, not necessarily leading to a mental illness as yet. Okay, possibly. So if we look at it, we are a special issue. Mental health is a special issue which was spoken to by other people. It's not from today where population issues, whether it's violence against women, HIV, AIDS, etc., it depends on the benevolence of the government in place. Whereas we are signatory states, Canada is a signatory state to UN conventions, which says that we will uphold human rights. If health is not looked at as a human rights issue, and within that, there's this notion of intersectionality. People have spoken about culture. 40 years ago, we spoke about culture, and I'm sure long before that, right? And we have to look at that all culture is not benign. Are we talking about the culture within or the culture without, or within our institutions? Because the barriers happen in all these places. People have spoken about representation. If it is not a politicized representation, we will reproduce the barriers by ourselves, our own bodies, to our own people and others. So having said that, if it is not looked at as a policy issue, as a fundamental core right of people to have access to barrier-free services. So what does barrier-free services mean? If we don't apply a human rights lens to it, and people have spoken about intersectionality, I no longer talk about intersectionality without a notion of racialized equity. Unless we apply a racialized lens in a white supremacist context, an anti-colonial lens with intersectional identities using race as an entry point, because all our identities are racialized. Otherwise, we reproduce also that certain people within our community will get services and not. It's not from an equity approach. I'm also raising what I used to say a long time ago, the race hegemony that has been created to by the white supremacists context, Canadian context, a colonial context, in solidarity with Indigenous peoples, right? Who have experienced it very differently. We cannot deal with the South Asian population without a consideration of ancestral trauma, as well as intergenerational trauma. And even being able to provide those resources. So if our frameworks are not clear from which framework we are setting up our services, we will reproduce services that will serve the best within our own community context. So if our aim is to really change the picture, we have to work from a bubble-up approach, which is bottom-up. So it will be the body of a brown person. We are talking about South Asians, whose all their identities are subordinated, which increases the likelihood of population issues, whether it's violence, whether it's HIV/AIDS, whether it's TB, whether it's whatever it is, that are compounding their lived experience. So we cannot do this work, and I can't emphasize this enough because we have fought for this in the anti-violence movement, in the women's movement, in the HIV/AIDS movement, in every movement where the control was with a white supremacist thinking. We were added on. And when we are added on, it is now you see us, now you don't. So I want to just leave you with a comment about the race hegemony, where I'm talking about how the white folks have done in the colonialist interventions, the divide and conquer between Blacks who are not homogenous, South Asians, and Indigenous people. I'm going to repeat something that I had said 20 years ago. And this is how it plays out. And nowadays, we can't even look at South Asians that they won't have biracial people and multiracial people. So one of the things I say is the hegemony is played out this way. Black people are feared, South Asian people despise, Asian people don't exist. First Nation people, now you see them, now you don't. If at all you see them doing the tom-toms and the healing circles and nothing changes. The politicians who are sitting over here in the audience, I'm going to say to you, the communication of policy has to be developed from the ground up. And you have a responsibility to ensure that the worst case scenario is integral to how we approach it. That's when the Human Rights Code, in its intersectionality, which is racialized. We cannot remove race from an anti-colonial lens to identity politics and population issues within the South Asian community. So having said that, if we don't, we will be simply add-ons, and it will be, yes, I forgot. Yes, we had to book the interpreter. which to go through it. Yes, that, you know, the food issue, that yes, that stinking food or whatever, the myths that they would create in the shelter movement and other sectors, hospitals, etc. So what I'm saying is to you is, wherever we are, we have a responsibility beyond our class interests to communicate whose interests are we representing wherever we are as South Asians. So I'm pushing the envelope of, yes, representation is important, numbers are important, but what I'm saying is not to be caught up that something will happen in a unique way. It's a flow. The resources have to be brought. If they aren't, we have to bring in the resources. If you'll need support, I'm saying you, I'm included in it. I'm a senior now, I'm almost 70. And I see myself as a service recipient in a much more different way now. And the risks of mental health and mental illness, very commonly. I'm a PTSD survivor, complex PTSD, because of ancestral and historical trauma and childhood trauma, etc. And I have spoken publicly about those things. So having said that, I think there has to be a space created. This is one of my strategies, recommendations, where South Asians have to come together and talk, because we don't have a homogeneous worldview on mental health and mental illness and how and where we enter the process. Is to have a conversation about whose interests are we serving? Where are we located? How can we bring other people into the picture, but ensuring that the most vulnerable in our community is taken care of, rather than a trickle-down approach, which is the white approach. A community, collaborative, community health, social determinants of health, etc. So this is my beginning take on it. And if I can in any other way contribute, if I use some pithy language, please ask me to explain. It must be about 3 o'clock in the morning now. I don't remember anymore. Not an apology. Okay, I'm really excited about coming back into the South Asian community where I withdrew from, because of our positions, which were very left, feminist, etc. Okay, and anti-racist feminist from an integrated intersectionalities from a racialized perspective. And that discourse has to come back and redeveloped and re-evolved, and how to work within our differences in the best interests of the most vulnerable person in our communities based on their identities and population issues. Thank you very much.
Thank you so much.
Stop me from speaking, because I could tell you stories.
No, it's okay. We can listen to you all the evening. Thank you so much. And thank you for sharing with us your lived experience and highlighting the importance of intersectionality when dealing with something as serious as mental health. And you've touched upon systemic change and how important it is and how it could be done. And Dr. Farah has also kind of mentioned that in a bit as well when he was speaking. I was just wanted to ask if anyone could elaborate a bit more on what the systemic changes that you think are needed in the mental health field in order to develop better resources and interventions for South Asian clients, on top of what Rita just said as well. Dr. Ripadaman, if you can start for this one, please.
Sure. I'm not sure if I have much more to add. I think there was some really wonderful thoughts in that first round of discussion. I think, you know, as a researcher and a clinician in this area, one thing I will say, though, is funding. And I think that targeted funding that is meant to address the inequities that we see in mental health research, and then also in the services that we provide. And I think those go hand in hand, right? Like we were saying earlier, that we need the research to be able to furnish the data to be able to back up why we need those services, and the barriers that exist as well. And I find that a lot of, in this stage where we're going through this, this time of reckoning with equity, diversity, and inclusion issues, a lot of the funding calls that are existing are very pan-cultural. So it's not targeted to the needs of specific communities, and certainly not for the South Asian community. So I think that's an area really that could help us on this journey, is being able to, really put money and policy, where our mouths are in terms of, the decision makers that exist.
Thank you so much. Manit, would you like to go next? And if I may just remind everyone, if everyone can speak for about 2 minutes for each question so that we can go through all the speakers and give everyone time to speak. Thank you so much.
I was just going to piggyback on that response. I think the funding, as it may be rolling out, the concern is it's going to agencies that are not able to reach the community. So a lot of other, organizations, for instance, that we've paired up with, funding has gone to X agency, yet they're still referring their clients to the agencies that are actually doing the work. So it's not directed to the agencies that have built the trust and the capacity to actually deliver the intervention. And so what ends up happening, when there's grant assessors looking at applications, there's an agency that's been around for 25 plus years, it's an automatic yes, as opposed to looking at the newer agencies maybe coming in with a unique lens. I think even having more protocols in place for partnerships, collaborations, and really encouraging that culture. I think in the nonprofit world, it's very cutthroat, it's very competitive, which is so sad because it's like you're all at this table looking for this small pot of money to all help the community, and you end up being unsuccessful. So I think there are a lot of passionate people in the field that ends up being very discouraging. They walk away from it. I mean, passion can only drive you so far. So I think that's a huge issue. And there's not a lot of representation in the individuals that are doing the assessments for grants, right? So I think that's another thing. You kind of blind over to the issues that exist, to the concerns of the community, because you don't understand the community's need. You don't have that language, you're too high up, you're far removed from the day in, day out. So I think that's an experience that we can kind of speak to, and of course needed targeted funding. You're like, we need the work, and I think it speaks to Dr. Naeem, we need the numbers to kind of show that. But I think it's working together and making sure the funding is available to the organizations that are actually doing the work.
Thank you so much, Manit. Jasmine, would you like to go next?
Yes, thank you. I think another systemic challenge is understanding the difference between equity and equality, especially for non-South Asians. I'll just generally use a term like Western communities and Western organizations, because nowadays, we have become very politically correct. We don't want to say the wrong thing, which in certain situations is needed, but we faced a lot of challenges. For example, we're based in the region of Peel. And we've already determined, a lot of the other speakers here have said that the South Asian community is not a homogenous group. There's so many differences, whether it's language, for example. And sometimes when we have tried to promote that these workshops that we're offering need to be done in Punjabi, because in the region of Peel, the top subgroup of South Asians is the Punjabi speaking community, we have received a lot of backlash because the organizations that are reaching out to us are not South Asian, and they're afraid if we do a Punjabi speaking workshop, then we're going to leave out the other either South Asian communities or non-South Asian communities that we are trying to target. And I think that's really difficult because you have to look at it from an equity perspective. It's not always just about equality. So that's definitely a systemic barrier that we have been facing. And that I think it definitely needs to be addressed. Of course, it's not going to change overnight. It's an ongoing thing, but that's been one of the challenges that we've been facing when trying to target or use a targeted approach for the community within the area that we're working in.
Thank you so much, Jasmeet. Dr. Parvati, do you have any points to add to this?
Sorry. I could say two things. One is about funding and also the systemic barriers. The funding, say for instance, the Tamil Wellness Center was started, it's called Vasantham Tamil Wellness Center, started in 1999, right after the research report came out of Mount Sinai Hospital and Wellesley Central. So it was established by the group. It's called Implementational Task Group. That's how it started. But still, we do not have a single full-time staff So the community and the community workers are concerned about the community. The community is going through a really, really bad time with addiction, with suicide, with various other issues like the domestic violence, elder abuse. So those are the things. Even recently we applied for Health Canada funding, but we didn't get it. But what we see is, the mainstream communities who are applying for funding, they are just given, even if they just touch or just did something, and they are getting, hundreds and thousands of dollars, and we see the disparity between that particular organizations and us. And we are doing much more work than those organizations, but we are not getting anywhere. And the other thing is that when you go to the emergency, say for instance, emergency, the communities that is reaching the emergency are really struggling a lot, because they go to the emergency only when they have a severe crisis, because the family members try their best to take them there, but they are not served. They are sent back, and the family members are not listened to. So this is where the frustration is. The community has lots of issues with the emergency staff, emergency department staff in the hospitals. And, some even come from another area to get a service from a Tamil-speaking psychiatrist, which is not allowed, because it is area-based. So there are no psychiatrists, anywhere. So they come to a psychiatrist where they can talk and discuss, thinking that they can go through the emergency. Otherwise, there's no way you can go. But even that is blocked. And this is where people are really frustrated, and how these people can be served. And the other thing is the seniors. The senior people are not really listened to, because most of them are unable to go to the services directly because of their lack of language issues and also the mobility issues. So they don't go there, but they are suffering. I have witnessed seniors who have really gone through hell in the apartments on their own, in seniors housing areas, and also in the nursing homes, So there's not enough South Asians to serve in the mainstream setups, whether it's a hospital or nursing homes or anywhere. So the mental health is not really diagnosed properly, and that is also an issue. Thank you.
Thank you so much, Dr. Parvati. So apart from funding, for example, for research, Dr. Farah, do you have any other input as to what systemic level changes are needed in order to develop better resources and interventions for South Asian clients?
So at the political level, it would be amazing for us to continue to push for universal mental health care. It's so imperative. We need it. Another one that I think is so important at the political level is to advocate for mental health crisis response teams that do not have police involved in those responses. We just need that, considering the racial profiling, considering the language barriers, other barriers that we face as South Asian populations. When those mental health crises do emerge or do happen within our communities, they can so often become violent and so tragic because police become involved. And so continuing to advocate and politically push for that is so important.
For sure, that's a very, very good and very important point about having the mental health crisis response team not include as many police individuals as it does now. Dr. Farooq, would you like to end that question with any input? Sorry, you're muted right now. Can you unmute?
Oh, I didn't know I was muted. Okay. Well, okay. So I think the funding is really two types. It's then research funding, and the second is implementation or service development funding that we're talking about. Okay. And in terms of research funding, it's a different game, you know, and you need to be part of the gang, and I am a part of the gang. So, and you know, Dr. Min asked that how it works. So that's a different game. So let's kind of leave that alone. There is no, I heard actually last year that actually CHR is going to start more specific funding for ethnic minorities, and they were putting like 100 million or something. Never materialized. I'm not aware of anything like about that. Okay, I am actually one of the things. I mean, I'm kind of kind of settling down in Canada, so and because my daughter doesn't want to go back to UK, so I think I'm thinking about long-term things now. We are planning actually to start a South Asian Mental Health Researchers Network, and we are so soon we'll roll that out, and we'll get in touch with the CASA as well and other agencies, you know, to kind of connect with people. It's all about gangs, simple as that. Second, in terms of implementation, now some of you might know we are running a large multi-center randomized controlled trial in Vancouver, Ottawa, and here in GTA of culturally adapted CBT for South Asians, all South Asians, not just one group. And now we have completed that almost, and but I'm just thinking, how are we going to implement the finding, right? What are we going to do with cultural adaptation? We have a plan of training, and I'm actually trying to make sure we have only white therapists, so we can train them in cultural adaptation. Obviously, you don't need to know about your culture if you're South Asian therapist, excuse me, white or non-South Asian therapist. So that's the second part, really, on systemic level, to engage non-South Asian agencies. I think that's a very important thing. We recently were invited by Ontario Social Work Association, and we provided training on culturally adapted CBT. We see, I think there are other issues which I think are very important. For example, I have a feeling, I don't know, I don't have any numbers. I have a feeling that South Asian first generation older people suffer the most in the West. You know, because your children grow up, they find jobs, they do all the kind of things, and they are still used to. And by the way, people of the same generation in India and Pakistan are very well adjusted because they had their lives, they grew up in different kind of way, although I'm not saying the conflicts do not exist. Divorce rate, I know everything. I know it's a complete, I wouldn't say mess, but you know, they are very westernized. Actually, some South Asians living in the UK used to be really annoyed because they saw South Asians living in India and Pakistan are more westernized than them. Okay, well, that's a different game. But the point is, that's a huge kind of area. So we need to think. We need to have a kind of a group of people who can actually work on these ideas. Which population needs to be? We need to focus on. Okay, I think older adults in North America and Europe, they actually are quite sort of lonely. They are more likely to have. Plus, your age range also increases when you are in these countries compared with, back home. You are more likely to live longer, and so I think that's another. And finally, and that's a very important area, we should not separate mental health from physical health. Isn't it true that your Peel area is known as, and I learned this recently, the diabetes capital of Canada? Do you know that? So South Asians have the highest rates of obesity. I run a CBT for obesity clinic, and 90% people are actually South Asians. So we should have a broader approach. We can't separate physical health from mental health. And I mean, just the diabetes, for example, the rates of depression are high in people with diabetes. People with depression are more likely to get diabetes. So we need to think about these things. We need to have a more in-depth look into these issues if we want to make a change at a broader level. Thank you.
Thank you so much, Dr. Farooq, and thank you all for your input for this question. I know that we don't have much time for the panel questions. I did originally want to ask you about the stigma, but I feel like we've already touched upon it throughout all the different questions, so I don't want to be repetitive. And I thank you all for mentioning as well throughout your conversations and throughout your answers, the importance of the lived experience and the importance of meeting the client halfway and kind of hearing what they have to say and how to shift or shape the interventions or the resources that you're going to provide to suit them as well, whether it's the culturally appropriate or not. As Dr. Farooq just mentioned right now, you can't really differentiate or distinguish completely between mental health and physical health. They are intersectional and they do affect one another. And I guess one of the questions that I wanted to ask, and it would be the last one for today before we go to the Q&As, is in your medical practice or advocacy work, have you come across clients or people in the public who don't believe, for example, that anxiety or depression or similar issues or disorders are medical conditions? And if so, how did you respond to them? And Rita, if I can start with you, please. Oh, and you have your hand up as well.
We do encounter that myth all the time, right? So having said that, that those are conditions that require medical attention, but they can also have, we have to consider, given the South Asian context, to integrate alternative ways of also addressing those. Because our population does go to Ayurveda treatments, homeopathic treatments, mindfulness, meditation, which is now a very Western practice, but not in the Eastern tradition. But I just wanted to, I agree with that kind of a commentary, but I wanted to say, in just rounding off the earlier discussion, if you don't mind, that research, policy, and services do not have to be competing with each other. They have to be fluid, right? One feeds the other, and which sort of echoes Dr. Farooq Naeem's statement. You cannot think after the fact of the research. In the research process, people from the ground who work in the field should be involved in the research. Research has become very institutionalized. We used to do research on our own on the ground. And for good reasons, it has been institutionalized because of the abuses that happen to participants. And I won't get into the history. Sitting in the academy at this point, we hear all these things and we have to be mindful of ethics, etc. And having sat on ethic boards, etc. So what I wanted to just raise the question of one of our colleagues said about equity and equality. I'm insisting on saying these things is that as we make progress and advance a cutting edge approach from the ground, from the margins, what happens is there's a re-entrenchment happening. Equity and equality, some of the issues that have been raised, they're equity issues. They should be funded, but the policy framework is one of equality and assumption of neutrality, that everything is everything and everything is equal. So we cannot, because research came from the ground when somebody came to our attention and said, I'm having this experience. And then the workers started talking about, we are seeing a trend, etc., and we would do it. So I think there has to be a union that not create hegemonies. There's a different kind of knowledge and a different kind of interweaving that we have to do between all three. So ethnicity has become the passing thing nowadays. There's no mention of race. You cannot do this work without racialized ethnicity if we are going to use a notion of intersectionality at the minimalist base. Equity and equality has to be embedded in policy in a very clear way, that you must work with the most marginalized and specific populations having specific population issues. So when Dr. Parvati raised the issue of suicide, it's a very high suicide rate in the South Asian community, Punjabis and Pakistanis in the Peel region. Diabetes, yes, right? I don't understand diabetes simply as a medical issue. I look at it in terms of the level of stresses we go through and ancestral traumas and traumas that we then congeal in our body. I'm in India at the moment for my brother who has colon cancer. We are survivors of deep trauma, refugees in India, etc. Okay, so he doesn't speak. He's got cancer. Okay, we are very wealthy, we are very rich, we can afford treatments, etc. But he will not go. He will not say what bothers him. My job is to make him cry in ICU and express his feelings. So I'm just saying to you, it's no different. We transport those things and the settlement process complicates it, and the colonization history comes with us. And those diasporic and otherwise has to be addressed. So I'm going to reiterate that once more, whereas we speak about culture, it becomes about white people do not have culture. It's the other that has culture. It is the other that has ethnicity. So what happens is that the dominant culture and ethnicities then prevail. So I'm pushing it again that if we all will disagree, we fought for this for a very long time in solidarity with indigenous peoples, is how do we, and we got fragmented and destroyed by policymakers. Any capacities the women's movement had, anti-racism movement had to make changes in policy. So I'll give you two examples and I'll wrap it up. Okay. I just spoke to a Trinidadian client of mine. She said, I attempted suicide again. Why didn't you go? And then I'll correct my language as a teaching also. Why didn't you? No, that's not the correct language. What prevented you from going? I can't have cops coming. They shame me and they say all kinds of awful things to me, right? Then when I go into the system, then they look at me as this exotic, erotic South Asian Trinidadian woman who have no idea of how much trauma she's coming from. And it becomes, oh, here she comes, the level of burnout in first responders. All those things have to be considered when you're seeing death. I'm sitting in an ICU unit where you can see how much at an advantage the Canadian context is in the health sector, where we are client-based and we'll ask for consent, etc. Nobody asks. I've witnessed somebody even smack somebody in the ICU to get them to comply. I'm going to write about it, but I have to make sure my brother gets treated and finished off, hopefully. So what I'm saying to you is that we need to come together and say, what is our bottom line, right, in helping each other? So if I need a researcher, I can go and say, Dr. Naeem, please help us. These are the issues. You'll have the language to do the grants, to shirk, etc. properly. Okay, so it doesn't have to become a competition, and that we can have a quality of funding submissions, as well as research submissions, as well as policy influences, where we hold not only our South Asian context people represented, but others. And also cannot stress enough that the South Asian community cannot take care of everybody, and that we cannot assume that all South Asian clients will come to us, because we can reproduce barriers for them. Right? If I didn't work with the LGBTQ community and I didn't identify as a lesbian, I would not be able to. And I've heard that from clients. That person is such and such, okay. And that kind of discriminatory attitudes, not only within, but also within the racialized communities, and also vis-a-vis the white people. Now I'm saying to you, racism and racialism are two different things. Racialized people, as in people of color, cannot be racist. Very, very clear. We don't have white skin privilege in the Canadian context. These are some political framework questions that I'm putting out, because you all have amazing things. I could tell you so much. because I worked in 8 sectors, saw the police stuff that was not at all appropriate, saw the health sector. You had to be constantly there to advocate for people. 2 o'clock in the morning, you're sitting over there in the hospital. Yes, you're a director in ED, just to make sure, because somebody's saying, Acha, your OHIP lapsed, we are not going to treat you. I said, okay, you'll have a slush fund in the hospital. Do you want to do it, or should I call the media? So I know how to work the system, but not everybody knows it. I learned it from other people. So I think there is a need for us to come together to say, okay, what is it that we can, and set up a strategic trajectory as to how do we work between nonprofits, the community stakeholders, as well as the clients themselves, as well as policymakers and researchers. We cannot be in competition with each other. We will not succeed, which is the reputation of South Asians, that we will pull each other down in our competitiveness, a legacy of colonialism. Right? We won't let it, which was echoed by the young people. It's an equity issue. It's a young, youthful organization. It should be given a place and promoted in funding, etc. Any of you young people who raise those issues, if you can contact me, I'll try and do my best to smooth the way. I still have contacts with funders.
Thank you so much. Dr. Rita Daman, you wanted to add something?
Sure. Yeah, I was just thinking about your question earlier, Yamna, about, this idea of, why doesn't anxiety or depression get understood as a medical condition? And I would say, in my context, even a step further, like, why doesn't it exist within our cultural community? That's a question I get a lot of is, so I'm seeing kids where I'm diagnosing anxiety, depression, autism spectrum disorder, ADHD, and parents will say, this didn't exist in our country of origin. And so some of the challenges with that, I think that are the conversations we have around that are, in many of our other languages, we don't have words to describe things like that. And when we do try to translate or culturally adapt some of our content that we're doing with our online programs as well, it gets watered down, it gets diluted when you say someone's just sad, right? Or someone has difficulty socializing, and that's not autism, that's not depression. There's more to it. And in English, we use these words and they've been coined and carry a different sort of weight and connotation to them. So I think that's one of the challenges with the community is, what do these words mean? The other thing, and with that, I try to bring up examples of people that they may know from their personal network. So whether it's someone from, within their family, whether it might be someone from their community or village of origin, to say, did you ever have someone who had, it seemed a little bit socially quirky, or someone who was very withdrawn, and just kind of bringing up the idea of, these things did exist. This is a part of the neurodiversity that we have. Around your question around, thinking of mental health, and in my context, developmental health as a part of our overall health and as medical conditions. Some of you may be familiar with the ACEs studies, and I draw on them quite a bit, the Adverse Childhood Experiences studies, which were, I think they're a couple decades old now, but essentially they were these studies that looked at about 17,000 Americans initially, and they looked at early childhood experiences that they had had. And so the questionnaire that they had looked at, had they experienced abuse, either physical, emotional, or sexual? Had they experienced neglect, physical or emotional? Or these markers of household dysfunction, which were mental illness, having a relative who was incarcerated, someone who had substance use challenges, divorce in the family, or a mother who was treated violently. And the more check marks that you had on that checklist, the more likely you were to actually have, physical manifestations of illness down the road as well. And so, I think this was a game changer for some of our predecessors in this space, where they were able to tie at least early childhood experiences and family markers of mental health and well-being to long-term outcomes, which included, so behavioral outcomes included lack of physical activity, smoking, alcohol, use disorders, substance misuse, and then missed work because it was an American study. And so they were looking at, economical outcomes related to that, but then physical health as well. So higher likelihood with those early experiences of having severe obesity, diabetes, as we talked about earlier, depression, suicide attempts, sexually transmitted infections, heart disease, cancer, stroke, chronic obstructive pulmonary disease, and even broken bones as well. So I think when you have data to back it up, like we were talking about, when you're able to connect those dots and say, these mental health conditions, these, and again, in my context, I'm thinking about how it impacts a family unit and how that perpetuates between generations as well. We see there are economic outcomes related to that, and certainly there are medical outcomes related to it as well. So I think maybe sometimes talking about those sorts of things, can help with moving that conversation forward and making it a more concrete thing that families can understand or agencies can understand.
For sure. Thank you so much, Dr. Ipudaman. And I think also like using the language for people to understand and just in layman terms as well. I think when people have a lot of medical terms thrown at them, all of a sudden they don't necessarily, they aren't able necessarily to interact with the information that is given to them or to actually absorb it. Dr. Farah, would you like to go next?
Sure, thanks. I think that was really beautifully said, Dr. Minhas. But just to add, when we're dealing with someone who doesn't believe that anxiety or depression or mental illness exists in the South Asian community, I think we have to sort of come from it from understanding that we're addressing a person's sort of deepest, darkest fears in a way. They're scared of the unknown. They're scared of what they can't control. And that's a lot of where those misconceptions come from. And so a lot of it kind of comes from an attitude of having to listen to their views and understand where they are coming from. Maybe it makes you angry. Maybe they will say things that you don't agree with. But trying to come to it with a listening ear, trying to probe further and trying to understand what that root fear is. Oftentimes we try to tackle those misconceptions logically, but often they come from a very emotional place. And why I also think it's so powerful to, what I try to do is leverage sort of my bridges within the faith community and to work within those faith spaces to kind of dismantle a lot of those, that mental health stigma that does have that religious flavor to it. Trying to draw on Islamic history or on scripture and trying to help people, hey, you know what, mental illness did exist. It's not this new thing. And here's evidence for it, but done so in a gentle way that is conscious of where people are coming from, speaking to people in the language that they can understand in a way that honors their faith or their culture and their languages, can be so powerful, just so they were speaking the same language.
Thank you so much, Dr. Farah. Jasmeet?
I'll just go quickly. I know we're short for time, but I think for both Maneed and myself, in the clinical setting as nurses and now in our non-clinical work with SOCH and working with the South Asian community, this is something we encounter all the time, especially previously to the pandemic when we would physically go out into the community. We see, South Asians sitting at parks and whatnot to promote our workshops. We would get this a lot. We'd be like, oh, hey, we're mental health nurses. We're doing this workshop. And immediately it's like, oh, no, I'm not pagal, which is like one of the Punjabi Hindi Urdu word for crazy. And at first, like, Dr. Farah was saying, it might even evoke like feelings of anger inside of you, because we're so passionate about it. And inside you're like, what the hell? And we would get that a lot. Like at first we would be like, what is going on? But then now we're so passionate about it because we're like, this is actually a moment of education and learning that we can provide to our community. In that, safe way. I kind of like what you were also saying, Dr. Farah, about, using like your faith and being like a softer approach. But I feel like analogies have worked really well for our community, and connecting the physical health and the mental health. Our community does tend to see a lot of physical health concerns over mental health. So when you're able to, be like, okay, well, you have a heart. So this is an organ, just like we have our brain, but we can't see the mind. So sometimes we feel like those analogies have really helped us to get our community to kind of understand that, depression, anxiety, excuse me, these things that we can't see do exist, and they are related to our physical well-being as well. And someone else had also mentioned it, but it got me thinking, like even in, if we're using like now Bollywood, some topics have been covered in these movies, even though they're not doing the best job. It's still a conversation starter, and you can kind of, use those, commercialized opportunities to kind of start that conversation. So it is starting. It's not, like I said, it's not always the best example, but, using those softer approaches, like even with Soch, we created a South Asian international students focused short film project focusing on mental health, and now we're going to be doing another one with a little bit more physical health issues. So using the creative arts and the art of storytelling to showcase mental health issues in a more softer and approachable way. I think that's also something that we have found is working, because you can show a short film and then have a conversation on it, or it just gets like your thoughts going like, oh, okay, these things do exist in our community. So just wanted to mention that, the analogies, connecting physical health to mental health, and using the arts and the art of storytelling, that's something that we found has started to work for us.
Perfect. Thank you so much. Dr. Fruit, do you have anything to add to that?
Yeah, there is another side to the story, and that's the number of misdiagnoses or overdiagnoses by the physician and psychiatrist. You see, when I moved to Toronto, I was in a senior management position, so I had often, these kind of families came with concern, and the number of South Asians with misdiagnosis was shocking. I remember, for example, a young second generation South Asian with schizophrenia was discharged by the hospital. I'm not going to mention which hospital where, although I'm sure most of you can guess. And the young man was discharged the second day because he was not talking. Now, South Asian schizophrenics, unfortunately, a big number of them, when they have schizophrenia, they go quiet, actually. So, right? So anyway, so many examples. That's a very serious side of the story, how psychiatrists misdiagnose, overdiagnose, or underdiagnose. And finally, there's a very funny side to this as well. I have, like you're contacted by friends of friends of friends of friends. So the last one, I'm going to tell you quickly, was contacted, and the family was adamant their 14-year-old daughter is really, really unwell, and I need to put her on a phone. I said, I can't do that. I can talk to you. So anyway, I spoke to them, and basically it turned out she's doing extremely well in the school, no kind of behavioral problems, etc., etc. And I kept asking, what is the issue? For God's sake, we think she has a mental health problem, and I think she needs to be treated. It turns out the poor kid wanted to color her hair blue. No, serious. I am very serious. And you need to think about this too. People have total misperception. If you don't listen to your parents, you have a mental health problem. Okay? So this is the third and very unfortunate but funny side, how people can twist these things. So if you're not listening to your parents, and vice versa, I've seen young people saying, oh, my father's gone total nuts, really, because he wants me to do this or that. So that's it. Thank you.
Thank you so much. And it's definitely a very interesting perspective to look at for this question. Thank you, Dr. Farooq. Dr. Parvati, would you like to give some final thoughts on this question before we move to the Q&A section, please?
Okay. There was an example that I think this young kid who was living in Peel region is a Tamil kid. But recently he, I think it's about almost more than a year now, and he committed suicide. But fortunately we interviewed the father and the sister. They have gone out of Peel. Now they are living in Vancouver because of the stigma. The people were coming to them and asking about it, and so they couldn't tolerate it. What I found out was the kid who committed suicide was not listened to by the father or the family. And so that because they are very, very engaged with demeaning jobs, so they have to do 2-3 jobs and they don't have time for the kids. And this kid, committed suicide. And until we intervened and we interviewed the family, they didn't understand that the kid had gone through racism, and that he was not listened to by the family. And that's why he committed suicide. So, the parents don't have time for them. So the younger generation now, they are really the trauma, the intergenerational trauma is really affecting them. I could see even, what one of the speakers mentioned about the LGBTQ, and even, there was another kid who died of, the parents did not understand him, and he only child, and he committed suicide because he was not understood, and he was an LGBTQ kid. But even after the death, the parents are very, very reserved, didn't want to. So they are unable to, come up with, just like the doctor mentioned about, making the hair, dyeing the hair. So that is not allowed. So these are the things that we are, facing right now with this intergenerational youth. Right now, they are facing a lot, and they are unable to get through. The parents are not really understanding. So we really need to have to educate, and we are that Vasantham Wellness Center. For the last 2 years, we started educating in the evenings. Big seminar we are doing through Zoom to educate the community, bringing the learned people, and so this is really helping the community, I believe. But all these things we are doing out of our concern, no funding, nothing. We are doing just because of to educate the community. So why? Because a lot of suicide is going on. So we wanted to prevent it the way we can, but the system is not helping us yet. So this is the situation for the ethnic communities in Canada.
Thank you so much. It looks like we've covered all our questions. Oh, Dr. Farooq, did you have anything to add, Rita, quickly?
Quickly, yeah. I think, to Parvati's point, I think we really need, I know we don't talk about this thing, we need to develop some kind of acculturation training for first generation people, especially, so they become at least used to the values of the dominant culture, so that, these conflicts at least can be resolved. So thank you.
Thank you so much, Dr. Farooq, and thank you all for your beyond valuable input. We finished all the questions that we had set up for now, but we will take a look to see for the Q&A. I just wanted to thank you all again for your extremely valuable input, for sharing your lived experiences, and for making sure that on the daily, the conversation about mental health has a room on the table, making sure that it's a topic that our communities, that is discussed openly within our communities, and one that is treated as seriously as you would any physical ailment or concern, as Jasmeet was saying, and as Dr. Farooq was saying, it's not something that is disconnected. I, for one, am very, very passionate about the topic of mental health, and it's been an absolute pleasure and truly insightful experience hearing all of you talk about it today, and just learning from your experience and from your expertise as well. Thank you so much. I'll hand over the mic to Mariba.
Hi, everyone. So because we're a little bit tight in time, we can only answer a couple of questions. We did have some of our panelists actually answer the questions in the Q&A chat box. So I guess I'll just read out the questions and answers. Actually, for the panelists who have already typed out their answers, would you like to read the answer out live? So I believe it was just me and
Sure. So the question was about the lack of culturally appropriate mental health services. So clients are always looking for language specific and cultural specific services, but there's not enough. And what do we have to say about that? So I was typing and I realized that there's a cap on it because I could have kept going. But essentially, I definitely agree with this because we at SOCH, we get so many emails asking for culturally and linguistically appropriate mental health support. And on top of that, the next question is it free or are there more affordable options? So, I mean, that's a whole other question and answer, but that's something that our community also struggles with. And I think it also goes back to that stigma and that lack of mental health literacy in order to understand that, you know, sometimes we do have to put some financial resources aside to improve our mental well-being. But that's a whole other thing. So essentially, I had said that, you know, we do need more South Asians participating in research because the evidence is what is going to get these programs funded. But of course, you know, that's a double-edged sword and it's a paradox because the stigma is what prevents, you know, South Asians from accessing research and participating in research. That's why I said this is a very multi-layered answer. I also spoke about, you know, the equity versus equality, and then how we need to get more comfortable with that, and even promoting existing cultural services to the community itself so that they know that these services exist. So that includes going where the community is rather than waiting for the community to come to these services when there's a problem. So really promoting that, that health promotion perspective, which is what we are trying to do. Because there are great mental health services that are catering towards the South Asian or ethnic communities, but the ethnic community doesn't know about them, right? So like one of my suggestions was setting up booths or having posters at faith institutions because that's where the community goes, or even grocery stores. You know, there's so many community boards. So finding out where the community is going and then promoting these services. Even using ethnocultural media, which is something that we found is working for us. But those were just some of the suggestions that I had or some of the comments I had for that question, but it's a very multi-layered problem that we are facing.
Thank you, Jasmine. I agree with you. More South Asians need to be involved in research and evidence because only we as South Asians can know our own community struggles and be able to provide the culturally and linguistically appropriate resources. We also need to bring mental health in general up in more conversations and destigmatize it. We also have another question. So Farah is actually typing up the answers, so you can answer this question live. So how can we possibly bridge the gap between youth and parents when it comes to mental health literacy?
It's a very broad question. Dr. Minhas actually touched on it as well, that importance and that need for early childhood education and maternal and child's promotion, et cetera, right upon landing, you know, having that as being something available to us right within that migration and resettlement process is so important. For example, that P parenting program, if we could tailor it to South Asian populations or have it you know, rolled out within South Asian community spaces or in our places of worship, it would be so amazing and be just an amazing support and strength for parents to be able to draw upon, because that communication gap, that intergenerational conflict, that cultural clash does begin to exist within that home. And that's where a lot of that those mental health difficulties start to occur within our South Asian families. Beyond that too, I mean, a lot of our South Asian community spaces and places of worship are having these sorts of great parenting and youth types of programs where they are trying to bridge that idea of the importance of mental health. They're having Mommy and Me programs, for example. I've seen that happening in the mosque. There are really great initiatives happening on the ground that if mainstream mental health organizations could recognize, could support, could offer and lend their funding that they have as well, it'd be so powerful.
Dr. Minhas, would you like to add on?
Sure, yeah. Absolutely. To echo what Dr. Islam was saying, I think there is a need, and this is one of the areas that I work in, is around parenting supports that are more culturally tailored. And with programs like Triple P, which is the Positive Parenting Program, they're very Eurocentric in their framework around, what does behavior management or discipline mean? What does the autonomy of the child mean? These are things that are very different for other cultural linguistic communities around those frameworks. And so, with our work, we see that, that initial struggle starts within that first year, even with feeding, right? With a lot of South Asian families really wanting to hand feed children, right? And this idea of this is an autonomous being that needs to be able to make their own decisions. And then, of course, that escalates all the way up to adolescence. And part of, the task of development of a child and a youth is to separate from their parents, to become independent. And I think that is really difficult, particularly for resettled families. I think there's a lot of layers there around what it means for your child to grow up, to become independent, to become acculturated, which can tie into this whole idea of losing culture and that identity as well. So I think there's a big need there around programs that are tailored to those unique sort of challenges that come up with families that have resettled. And bridging the gap is difficult because, we know that our kids are having these conversations at school and in the media. We're hearing about, there's so much awareness around neurodiversity, gender diversity, the various sorts of things that we're hearing struggles with parents as well. And so I think we need to continue to educate moms and dads and grandparents around this as well, and then trying to create space for conversation around that. I know there's been a big interest with our channels where we focus more on early childhood, but to create a Punjabi teens or Tamil teens health channel as well, to have more of that, because there just isn't space for those sorts of conversations. And for many homes, that's not the space either.
Dr. Parvati?
What, we are talking about the younger generation. So what we learned after the COVID situation, a lot of South Asians did not send their children to school. It's online school, it was. And what we also see, we have done some work with the children. Right now we are doing it. And a lot of kids, parents are going through a lot of problem with the younger kids who are having gaming addiction. The gaming addiction is the biggest addiction right now going on with the South Asian kids. And so that is going to affect their mental health. And so we have to do something about it. It's unfortunate that our South Asian parents did not send the children. Most of them did not send them during the COVID. And even now, there are many who are not sending the kids still. So those kids, many kids have this problem.
Thank you, Dr. Parvati. Sorry, looking at the time, we don't have much for more questions. So I'll just quickly wrap it up. And I just wanted to thank and I appreciate everyone for being here and celebrating South Asian Heritage Month and Mental Health Awareness Month. And we appreciate you sharing your experiences with and treating mental health. And we really hope that there will be more conversations in mental health in our own communities, and of course, better interventions and South Asian focused research. Thanks again for joining us today, and I guess we'll see you next time.
Thank you, everyone.
Thank you. Bye-bye.
Thank you.
Thank you again. Bye.
Thank you, everybody. Take care.